You published a review in JADA recently about the efficacy of a combination of ibuprofen and acetaminophen to manage pain. What were your conclusions and what are the clinical significance of that?
The use of those two drugs, two non-opioid drugs, ibuprofen, which is Advil, and acetaminophen, which is Tylenol, it's always been suspected that they might have some additive effects, some way that they actually provide greater analgesia than either one of those drugs alone. And it's kind of based on an old pharmacologic principle that when you combine two drugs that have different mechanisms, that when you put them together, you can get additive benefits. But the data was never there until about 4 years ago, and we're beginning to see some clinical trials that really demonstrate that this is pretty remarkable in terms of how much additional analgesia, particularly in our inflammatory pain model, that you get with that combination. And clinically, what's important, it seems to me, is we have always been kind of in this position of either taking Tylenol or taking ibuprofen, Advil, or having to take Vicodin or Percocet as our analgesic. This actually gives you a position where there's kind of another level, another step in our kind of continuum of analgesics from mild ones to moderate ones. Now we can throw in this combination, and the findings are that this might be opioid sparing in the sense that it doesn't require that you use Vicodin. All of a sudden you have an alternative to having to go to an opioid.
Wonderful. Now you mentioned Vicodin and Percocet. Do you think dentists are over-prescribing when it comes to those type of opioids?
I mean, over-prescribing is just a loaded term, I think. We have a dilemma, and it's a dilemma that we see in dentistry, we see it in doing bunionectomies, we see it when we do orthopedic knee surgery. And the problem is we do surgeries on an outpatient basis, we prescribe a drug when the patient is still numb, so we don't have any idea how much pain they're going to have. And what we're prescribing for is how much pain they may or may not have in 3 days or 2 days. And the question then becomes, how do we know who needs it? And the answer is we don't know for sure. We did a wonderful study where we, instead of looking at what was prescribed, we looked at how many of those opioid pain relievers was actually used by our patients. And what you see is about 15% of the patients don't want to use a Vicodin or a Percocet. They don't fill it and they don't use it. You see a couple patients, 2 or 3%, who in fact have dry sockets and have extreme pain, and they need more than we give them. But in that middle section there, on average they use eight tablets, but we don't know who needs what, and we're at a loss on how we can make sure they are not having pain, because that really is our first job, is to treat our patients. But we also don't want them to leave 20 tablets sitting in a medicine cabinet unsecured. Therein lies our problem.
You also use the term opioid sparing. So are there any strategies involved in using opioid sparing when it comes to acute management of pain that dentists should be aware of?
Well, I think what we're doing now is, both in medicine and in dentistry and in podiatry and all of our surgical fields, is we're trying to think of ways that we can prevent pain, and particularly prevent severe pain. And if we can use mechanisms that keep you from having severe pain, then the need to use opioid analgesics is going to decrease. And it's been shown in a couple models. In dentistry, I think the first one I recall was a work using Marcaine, maybe 50 years ago, that if in fact after surgery you use a long-acting local anesthetic, well then the patient is numb for 6, 8, 10 hours and doesn't need to have a real strong opioid pain reliever. Additionally, in oral surgery, we're kind of accustomed to giving steroids, corticosteroids like dexamethasone, that prevent swelling and decrease the discomfort postoperatively. And most recently, I think we're seeing a use of nonsteroidal drugs, drugs like naproxen, drugs like ibuprofen, and to offer those and give those to patients before they leave the office, before they're ever in pain, to try to get blood levels established so that you decrease the need for opioids in the 6, 8, 10 hours after surgery. It's a reasonably good strategy. It falls into that multimodal pain management model that we all talk about these days.
So you said decreasing the use of opioids, so there's still a place maybe for the use of opioids. And would there be any strategies on how to teach dental students and dentists how to use opioids in case it's needed?
Well, I think we're really moving in that direction to a great extent. I mean, I think there's new curriculums being developed in terms of how we teach opioid prescription writing and safe prescription writing. For our students, there are a number of things that we talk about. One is just the basis of is it appropriate to give an opioid to this patient? Do they have a history of abuse? Are they pregnant? Are they on drugs that may have caused drug interactions? That's kind of the medicine part. Probably you know more about that than I do. But on the other hand, we like to think about how we could instruct patients, counsel patients on how to go about using this prescription we're offering. That instruction for me and what I teach is, Mrs. Jones, this is a prescription for an opioid. You may not have to fill this at all. I'm giving it to you so that you have it on hand in case you do need it. But 60% of my patients aren't going to ever require an opioid to manage the pain. The pain is never that severe. So that kind of counseling on what to expect post-operatively becomes an important part of what we do. And then we give those specific instructions that we're now talking about. Don't share this drug with anybody. Make sure you keep it secured, lock and key, so that nobody else is using that drug. And make sure you dispose of it properly after 7, 10 days after you no longer need it.
So opioid drug abuse still exists, obviously. So is there a place for dentists and even ADA in the help of combating this type of drug abuse that exists in this country and elsewhere?
Well, I think we're all really alert to the kind of increased use of opioids, misuse of opioids. Overdose deaths in the United States have dramatically increased. And I think all of us, physicians, dentists, patients, law enforcement, regulatories, even the President of the United States at this point, are all interested in how they can jointly collaborate and cooperate to try to decrease this misuse of opioids. In honesty, in the last couple years, there's really an indication that prescribing has decreased, that the problem is not so much prescription drugs as it has been, but now it's moving into illicit drugs such as heroin and fentanyl, and the overdose deaths are being reported for that kind of use rather than misuse of a prescription drug.
In the July issue of JADA, you and your co-authors have written a commentary about Vicodin versus anti-inflammatory drugs. Do you want to make any comments on that for the audience?
Well, I mean, we've been arguing for a long time about the fact that in inflammatory pain, in post-operative dental pain, the nonsteroidals invariably are more effective than the opioids, particularly the way we prescribe opioids, 1 tablet, 4 to 6 hour kind of prescribing of Vicodin. The nonsteroidals really work better, and particularly the combination of a nonsteroidal with acetaminophen, it just shows extreme efficacy compared to Vicodin. But there's a lot of reasons why we prescribe Vicodin. Sometimes it's just the patients demand it of us. Now, that's probably not a good reason to write a prescription for an opioid, but we recognize pain management is the holy grail of good care, of compassionate care. What a patient knows is whether they hurt or not at the end of the day. And so we're pretty sensitive to making sure that we do everything we can for our individual patient to make sure they're not in pain. The problem is, what happens if this is the patient who doesn't need more than 1 tab or 2 tab or 3 tab? Then you get this unused part that you really need to instruct your patients that you need to secure it and dispose of it properly.
But there are contraindications for nonsteroidals, ibuprofen as well as acetaminophen and so on and so forth, where maybe opioids may be the alternative of choice.
I would never suggest that we don't need to have opioids as part of our armamentarium, our management tools. Most of the side effects and contraindications for nonsteroidals are long-term use, not short-term use. And so to a great extent, most of our patients are going to do well on a nonsteroidal. But I think there are times when the pain is really severe, when you're talking about a dry socket, when you're talking about a very acute odontogenic infection. The nonsteroidals may not be able to cover that, and that you may need to go to an opioid pain reliever at a reasonably good dose to be able to manage that pain with an oral analgesic.
Do you want to add anything?
There is one thing that makes us unique, and I think you really need to stop and think about the fact that most of our prescribing, not most, but a great deal of our prescribing, has to do with taking out wisdom teeth. Well, now we're talking about young adults. We're talking about adolescents. And if you think about your own experience and your own kids, the first time they ever saw a Vicodin was probably after they had their wisdom teeth taken out. I mean, think about that. It only occurred to me 4 or 5 months ago. This is really why we are sometimes in the crosshairs with the media, because not that we prescribe a lot, we in fact don't prescribe a great amount of these agents, but we're the first. And you know, if somebody is going to get in trouble with alcohol or tobacco or anything, it's that first experience that can really be a problem. And I lecture very heavily that we have a special opportunity and responsibility, but particularly an opportunity to stop and say to this 18-year-old who's just had his wisdom teeth taken out, this drug has some very dangerous potentials in terms of misuse and abuse, and you need to be very careful about doing that. And I think that's one of those teaching moments that I think we all ought to think about when we prescribe, particularly to an adolescent or a young adult.
Great. Mm-hmm. Thank you very much, Paul. Thank you for coming.
I enjoyed it. All right.
Thanks.
We'll do it again sometime.
Anytime.